you understand. I request all of you to keep your videos on. Not that I want to know if you are here, but just to see some faces and probably understand if you are following through the sessions. Okay, I see some familiar faces here.
Good evening, sir.
Good evening, ma'am. Okay, so for the next 1.5 hours, we will be looking at how food is managed in a palliative care setting and few important aspects on how differently we manage wounds in palliative care settings. I would like to run through my slides first. I know that you already went through a video and all this is kind of last minute. Shiba Chechi is not well, so I had to pitch in at the last minute today. And after I finish my slides, let's see we can have some discussions and clarify if there are any questions. Before I start, sir, is this the number expected or is there anybody else? Is there anyone else yet to join?
Few more we are expecting.
Okay, I can start. Right?
Yes, you may start. They will start.
Okay, I want to start with this question. Have you ever injured yourself in your life? I know that most of you, I think most of you will be older than I am, so with lots of experience. Have you ever injured yourself in your life? Can I just see show of hands? Okay. When you injured yourself, did it require daily dressing? Not a small injury, but a significant injury where it required uh, daily dressing.
Yes, sir.
Okay. So you know what I'm talking about. So you know that experience, okay, of going through an injury. So when a patient, let's imagine a situation where you are in an OPD or you are in an emergency room, a patient comes to you with a road traffic accident, okay, uh, not a very serious road traffic accident. So he comes to you with say multiple lacerations in his say upper and lower limb. What do we do? You can feel free to unmute and speak. So when a patient comes to us like that, what is that we do to them? Not serious lacerations, but lacerations here and there. What do we do? So I don't
For
hear any.
normal lacerations, sir.
Yeah, say slightly deep. Okay, in their hand and in their
Just
leg.
clean we just
Yes.
wash the wound, clean the wound,
Clean the
and
wound,
apply
then
some antiseptic, and that's it.
yes, that's
Clean
it.
the
So
wound and apply some antiseptic solution or
okay. So we
and
clean
then
the wound.
tell them.
Okay, then yes. Apply some antiseptic, then yes, please carry on, ma'am.
And then we tell them to clean the wound every day and
Very
apply
good.
that antiseptic every day. And in case there is any pus or fever comes up, then they have to contact us again. Otherwise, we don't give
Yes.
any antibiotic for smaller lacerations or smaller.
Yes. Yes. Okay. So we give them some follow-up instructions. Okay.
Yes, sir.
Yes, and we tell them, we insist that they dress the wound according to what we decide as the frequency to be, sometimes daily dressing or an alternate day dressing depending on the type of wound and how serious it is. Okay. Uh, if the patient comes back and we notice that there is some infection, we resort to prescribing antibiotics. So what is our ultimate aim in all this? Why are we doing this?
Wound healing.
So that will be our aim. Okay? And that is what we tell the patient. When we manage wound in a conventional setup, in a general practice, we have one aim and all our management is directed towards that. We clean the wound so that it doesn't get infected. We prescribe antibiotics so that the infection doesn't delay the wound healing. We insist on daily dressing so that we promote healing, okay, and reduce local infection, okay, reduce all the dead cells by cleaning and washing. All this with one aim, that is wound healing. Okay, let's imagine one patient comes to you. You are sitting in a palliative care OPD. One patient comes to you. He has a big fungating ulcer. Say he has a diagnosis of carcinoma buccal mucosa, and the ulcer is fungating. There is a fistula, and all the imaging shows the malignancy has infiltrated into the bones. Okay, patient has undergone this chemotherapy, radiotherapy. Okay, and the surgical oncologist has ruled out surgical intervention as a means of helping the patient. So what do we do at that point? So you understood my question?
Yes, sir. So I feel at that time we should try to comfort the patient. Of course, as you mentioned, it's a fungating wound. It should have some smell associated with it. We should try to eradicate that so that patient feels comfortable. Daily dressing is what we could do. And the patient will be psychologically distressed as the body image has changed. So we can give them counseling as a overall support we can offer to the patient.
Okay.
We can give analgesics. We can give analgesics,
Very good.
local analgesics, Prilox cream, or something before doing dressing, or spray lidocaine.
Okay. Anyone
We should
else?
also take a wound swab and see if there is any culture, if it is positive, and give empiric antibiotics till then. And then once the swab report comes, and switch to those antibiotics.
Okay, wound swab for a chronic wound is a very controversial thing. We'll come to it later. But definitely, if there is infection, we'll try to give. Basically, my question is, will it be any different from a person who has a wound that you're expecting to heal and the person who has a wound and that you are expecting not to heal in terms of management? Both sides, will you give analgesics? In an acute wound, if it is serious enough, we will give analgesics, but only it is going to be short term.
Venous ulcers and all. Chronic venous
Yes.
ulcers, they are not painful, but the infection, it's still there. It's a chronic kind of.
Yes.
So it's
Yes.
not required analgesic.
See,
Not always.
some vascular ulcers are extremely painful. So, for example, you said venous ulcers. What about arterial insufficiency ulcers?
They will be
They should
painful. So not
extremely painful.
each and every wound might not require analgesics.
Yes, that is true. Even in malignancy, if there is a malignant wound, does not mean they will have pain. Usually, they are likely to have pain. What I'm trying to say is, in an acute wound and also in a chronic wound, in terms of wound management as such, the things that we do are not very different, but there are very specific malignancy related issues that we try to address. But the goal is very different. One side, in an acute wound or a wound that we expect to heal, okay, we look forward to that goal and make our management plan directed towards that. In a malignant wound, which are, okay, for example, in a non-healing malignant ulcer, which is going to be a long-term problem where wound healing is not possible, you still dress. you still give analgesics. You still teach patient to care for themselves. Lot of things that we do are overlapping, but the wound is not going to heal as an outcome as such. This difference is very important for the patient. So that is why I asked you, have you ever had a wound in your life in the past? When you know that your wound is not going to heal, okay, and you are still expected to care for that wound daily, what is that psychological impact that is going to have on you, on me? We should always keep that in mind, okay? Because, okay, this is going to be a frustrating experience. I remember one patient when I was there in Calicut, okay, he had a, I said specifically carcinoma buccal mucosa because that is a real patient. He had a very small malignant ulcer sitting, and but problem is it had already invaded into his bones, and he had completed several rounds of treatment, and not all treatment options were ruled out. But he has come to this palliative care OP, and the nurse dressed and sent him home. He's about 30 kilometers away. The next day he came. It was dressed and he was sent home. Next day he came, he was dressed and sent home. This person kept coming back again and again. Every time his wife also came with him. And one day this nurse asked him, we every day teach you to dress the wound by yourself. We teach your wife so that she would dress the wound. But why do you keep traveling 30 kilometers every day? 30 plus 30 is 60 kilometers. And this man replied, if my wound is dressed by my wife, it is not going to heal. But the nurses here are good. If they dress, it is going to heal. Okay. The non-healing nature of the wound was explained, but this person had extreme difficulty in accepting it. He was always looking forward to healing. And lots of communications happened. This person kept coming back again and again. But one fine day, this became a fistula. Okay. And every time he ate, it was leaking through the fistula. And that was his tipping point. Okay. And that point, he stopped coming to the OPD. Okay. 2 weeks he didn't come. And third week, the wife brought this person with full of maggots. And when asked why you didn't come, he said, what is the point? It is not going to heal. So this is going to be, that is what I'm trying to convey. Management of a malignant wound is going to be a frustrating experience for the patient. You have to care for the wound meticulously, and it is going to be an ugly, painful wound in some cases, not in all. But then I cannot expect the wound to heal. There is this delicate balance where we teach them the importance of caring for the wound. At the same time, there is a need to protect them from unrealistic expectations. And this delicate balance between the need for caring for the wound and not having unrealistic expectations needs to be achieved much early in the course of our wound management, or else we are likely to miss this patient. We are likely to, the patient is likely to go for a loss to follow. He will probably default, and at some time the wound will get worse and they will come back. So that the delicate that, sorry, just 1 minute. Interruption. Okay, let's go to the slide. This is something that I wanted to say in the outset, where this delicate balance of the need to manage the wound meticulously and protecting the patients from unrealistic expectations needs to be achieved much early during the course of the treatment and not later. The message that this is going to be a non-healing ulcer needs to be communicated very clearly to the patient. In a palliative care setting, we see a lots of non-healing ulcers. Most common non-healing ulcer that we see in any general practice is diabetic ulcer. Then we have venous ulcer, arterial insufficiency ulcer, pressure ulcers, and along with this, we also have malignant fungating ulcers. In a palliative care setup, the first three types are rarely seen, not very as common, but pressure ulcers and fungating ulcers are very, very common. Just to give a small orientation on diabetic ulcers typically have this punched out appearance. This punched out appearance of skin is very typical of a diabetic ulcers. The reason when the blood sugar level is consistently high, patients nerves are damaged, both sensory fibers and motor fibers are damaged, and this damaged motor fibers kind of alter the anatomy of the foot. Okay, there is subluxation, which results in a lot of the foot is not flat, but it is curved. Okay? And because of that, there is a lot of pressure on this metatarsal head. So typically, these patients develop a callus over the metatarsal head, and over time, this callus breaks out and they develop a punched out appearance. And because their sensory fibers are also damaged, and this is not painful and often goes unnoticed. Then we have venous ulcers. As ma'am was speaking earlier, venous ulcers are mostly not very painful and they have a very typical appearance. As you see this wound bed, the venous ulcers wound bed is usually beefy red, okay, which is very different from arterial ulcers, which is usually pale. Venous ulcers wound bed is beefy red, okay, and you can see a lot of black spots in and around the venous ulcers, which is basically this hemosiderin. Because of the prolonged vasodilation, the RBCs that leak out of the capillaries settle within the interstitial space and then they break and the iron content remain. So it is like a hemosiderin stain. And other typical features of venous ulcers are they usually come and go. Patient will develop small ulcers in one area and slowly it will heal. And after a few months, it will come back on the same spot. So venous ulcers are usually recurrent. They come and go, and then slowly they become chronic. Other features is that venous ulcers are more common near the malleolus, especially medial malleolus. And patients usually have a swelling which improves when they elevate their leg. So these are some features of venous ulcers. This is a feature of arterial ulcer. Just by looking at this picture, can you just tell me some features that you notice in this patient? This is very, very typical of arterial ulcer. We will not see such very typical features always. If you see this leg and this wound, are you able to notice some typical features that we see in an arterial ulcer? Okay. Gangrene. And you see it is not a wet gangrene, it is dry. Okay. That is one thing. Very good. Anything else?
Swelling of the foot.
Yes. Swelling. Anything else? Not, the swelling is not always there, but
Cellulitis around the
yeah, probably this wound is getting
wound.
infected, so there is some inflammation around the wound area. Anything else? If you look at the skin, you see as if the skin is very thin, about to break. It looks as if the skin has lost its thickness. Okay. This is very typical of patients with arterial insufficiency because of poor blood supply, and that blood supply is not able to meet the demands of the metabolic demands of the skin. Over the times, the skin will lose its collagen and the skin will become very thin. Okay. Interestingly, you see, are there any hair on the skin? It looks as if it is shaved out, no? This is another feature of an arterial insufficiency. Patients with arterial insufficiency will lose their hair. And as I said earlier, the wound bed is always dry. And if there is no gangrene, if you are able to see the wound bed will be pale. Opposed to a venous ulcer, the wound bed is beefy red. And these patients always complain of this claudication pain. And if you touch the skin, it will not be warm, it will be cold because the blood supply is inadequate. Then we come to pressure ulcers. This is one of the very famous statements about pressure ulcers. When a patient develops pressure sore, it is not the problem of the disease, but the problem of nursing. Do you agree to this statement? The nursing here is not nurses. The nursing here means caring. So which means it includes everybody in the team. Nurses, doctors, family caregivers. Sometimes if the patient is able, the patient themselves. Any idea who said this?
Florence Nightingale.
Yes, okay. The pioneer of modern nursing itself. Okay. When during the Crimean War, she was caring for the soldiers, and many of these soldiers who are bedbound developed pressure sores. And that is when she was teaching the nurses, she said this: when the patient develops the bed sore, it is not the problem of the disease, but the problem in caring. Pressure sores are a lot easier to prevent and to manage. Once they come, and when they get very deep, very difficult to manage. Pressure sores are nothing but pressure-induced skin and soft tissue injury. Superficial skin gets injured and the soft tissue beneath, subcutaneous layer, muscle, and also the bone get injured. So what are all the causes for bed sore? What causes bed sore? So again, everybody has turned off their video. So I'm not even sure you're here. In your practice, what kind of patients have you seen to develop bed sore?
Patients with brain tumor or brain metastasis who are unable to non-ambulatory.
Okay. Patients who cannot ambulate themselves, who are dependent, okay, bedbound.
Chronically sick patients with
Yes.
poor blood supply to the to a body part can develop pressure sores,
Yes.
and who can't change their position.
Yes. Okay. Basically, patients whose mobility is impaired. Any other patient group have you seen to develop bed sores? Another patient group is paraplegics. Okay. who cannot feel pain. Paraplegia is below their base at the level of injury, they cannot feel pain. Those patients, very bad bed sores they develop, and most of these paraplegics, if you go to the plastic surgery ward, many of them come for flap. So extrinsic causes externally, there are four mechanisms with which pressure sore happens. One is pressure, which we all said. Pressure will cut off the blood supply, and that results in a ischemic injury. There are few other mechanisms which, if we are not careful, will result in pressure sore. One is friction. If you had worked in ICU, we usually prop up the patient's head end. Okay, and morning a nurse would have propped up the patient. By that time, if you notice, patient would have slided down by afternoon time, simply because of gravity. They will slowly slide down, and attender and everybody will be called. Again, they will lift the patient, put them back in a propped up position. This is very typical thing that happens in any ICUs. Okay, this act of patient sliding down and the act of others trying to lift the patient and put them back on, this act causes a lot of friction. Okay, the skin in the buttocks, specifically the sacral area, gets peeled. So friction is another one main cause. The other one is shear. Shear is especially in the area around discal tuberosity. When the patient slides down, the bone moves forward, sliding down. Because of the friction, the skin tries to remain close to the bed. So there is a difference. The bone is moving forward. The skin that is in close contact with the bed remains there, and that causes shear. That difference is shear, and the resulting strain causes injury and results in bed sore. So four different mechanisms. If we are able to negate this four different mechanism, we can protect the patient from bed sore. So other than that, there are some patients who are at the higher risk of developing bed sore. One is age. Age patients tend to lose a lot of subcutaneous fat. So the bony prominences are significantly high, and they easily develop injury. Lack of pain perception, as in patients with spinal cord injuries or say stroke, where they are not aware, bedbound, they develop. And malnutrition has a lot of increases the risk of bed sore significantly. This is proven with lot of studies. If you correct nutritional status in an ICU, you protect the patient from lots of problem and improve survival. So nutritional status is very important. Urinary and fecal incontinence is another issues. Okay, the moisture around the area makes the skin very moist and soft. The skin simply peels off, and that is also a very suitable environment for growth of fungal infection or sometimes even bacterial infection. So, and when there is a bed sore and there is associated fecal and urinary incontinence, you will see that the bed sore is getting again and again infected again and again, and which delays the wound healing. So this is also a problem. So patients with other comorbidities, diabetes definitely delays wound healing. Vascular injuries, definitely vascular diseases, delays wound healing. Patient has other risk factors like smoking, again, wound healing is delayed. So these are all some risk factors. Pressure sore only occurs in pressure point. If there is a sore which is not in a pressure point, it is not a pressure sore. Okay. So we have very few specific pressure points when the patient lies down flat: occiput, scapula, elbow, sacrum, and heels. Okay. Buttocks. Okay, these are all the pressure points when the patient lies down flat. On the sides, then ears, shoulders, ribs, iliac crest, greater trochanter, lateral condyles, and lateral malleolus. And the patient lies down prone, there are specific areas. When I was working in Calicut, we heard a news from one of the hospitals after a long orthopedic surgeries on a patient's spine. When they turned the patient, the nipple had necrosed. It can happen simply because of pressure injury, prolonged proning, and somebody was not careful when they placed the patient, and patient's nipple had necrosed. So these are all the areas are prone for a pressure injury. Then we have few stages of pressure sore. Typically we have 4 stages. Stage 1 is a most superficial stage. One important characteristic feature of a stage 1 pressure sore is non-blanchable redness. In stage 1, often mistake is made. They will see a small laceration and then they will say it is stage 1 pressure sore. But keep in mind, in stage 1 pressure sore, the skin is intact. Okay. When the skin is not intact, then it is not stage 1. It is either stage 2 or onwards. Okay. What is seen in a stage 1 pressure sore is a non-blanchable redness. What is non-blanchable redness? My head is, if you can see my hand, it is pink. If I press against, it turns pale. Okay, that is because I am able to push the blood away from that area. This is blanchable redness. But if the redness is due to inflammation, if I try to blanch, it will not get blanched. Okay, so non-blanchable redness is a characteristic feature of a stage 1 pressure sore. And usually it is painful. And in stage 1, the skin is intact. In stage 2, the skin is no more intact. The integrity is broken. What we say is a partial loss of dermis. Okay. It can extend into the dermis. Epidermis is broken and it can go up to the depth of dermis. Usually it is painful. So if sometimes stage 2 pressure sore will look like just a bleb with a fluid filled bulb, or a skin is broken but not very deep. So this is how a typical stage 2 pressure sore looks. Okay. And it may leak some serosanguinous fluid and can have blisters. Basically, the skin integrity is broken in stage 2 pressure sore. In stage 3, it gets little more deep and extends into the subcutaneous tissue, okay, where the fat is. So usually it has reached into the subcutaneous layer, and at that point we call it stage 3 pressure sore. But keep in mind, in those who are malnourished and those who are elderly, this stage, the progress from stage 2 to stage 4 can be very rapid because of inadequate subcutaneous fat in elderly and in malnourished people. First day you will see a stage 1 or stage 2 pressure sore. By third day it will be stage 4 pressure sore. It will evolve very fast. So in stage 4, it has gone very deep into muscles or bones. The moment you see muscles or bones in a bed sore, then we call it stage 4 bed sore. Okay. There can be undermining or tunneling. Undermining is there is a space between skin layer and the muscle layer. Usually there is no space, but because of infection, if you put your finger underneath the skin, there is enough room for your finger to move around between the muscle layer and the skin layer. So that is what undermining is. Tunneling is within the wound, there can be a tunnel that goes much deeper, like a fistula. So that is common in a stage 4 bed sore. If you see undermining and tunneling, it is a sign of infection and the patient should be started on antibiotics. Okay. This is a conventional staging of bed sore. Other than this, have you heard of any other stages? These stage 4 is what probably I learned when I studied in my nursing school. But there are few other stages of bed sore. Just have a look at this image. Can you stage this bed sore? What stage it is? You can put it in the chat or please feel free to unmute. It's difficult to ascertain, correct? If you look at this area, we know that the skin is damaged. So the area that is pink, you can fairly surely say that it is stage 2. But what about this area? I think somebody tried to, yes, very good. It is what we call an unstageable bed sore. Okay. The idea is when we stage the bed sore, we always look at the wound bed. Okay. Skin is not broken. There is non-blanchable redness, stage 1. Skin is broken at the base, stage 2. The wound has gotten deeper and reached subcutaneous layer. We have looked at the base, stage 3. It has reached muscles or reached bones, stage 4. We always looked at the wound base and staged the bed sore. But here the wound base is actually covered. This is an eschar. Okay. Sometimes this dark dry patch will not be there. There will be a slough, a yellow patch or yellow sticky substance on the wound bed. Slough or an eschar can cover the wound bed. So we call it unstageable bed sore. But keep in mind, when you look at an unstageable bed sore, it is either stage 3 or above. Slough and eschar is not usually a prominent feature of a stage 1 or stage 2 bed sore. We can be fairly sure that if there is slough or eschar, it is either stage 3 or a stage 4 bed sore. What is this? This is also a pressure ulcer.
Stage 2 and stage 3.
Okay. You see, ma'am, why do you say that it is stage 2 or stage 3?
Stage 2 and stage 3. Stage 2 on the outer periphery and stage 3 on the inner part.
We do not know, no, it is covered. Okay. This is a very typical feature of a deep tissue
Okay.
injury. Okay. See, when we stage the bed sore, we should not assume that the bed sore will always start from the skin and go inside. Okay. Rather, the bed sore can evolve from underneath. Okay. Sometimes when the pressure is too high, the muscle may be the first tissue to get ischemia rather than skin. Okay. And the deeper tissue will be the first tissue to become ischemic, and the patient, and that point we call it a deep tissue injury, which is a feature of bed sore which doesn't conventionally fit into the stage 1, stage 2, stage 3, and stage 4. And deep tissue injury are often poorly recognized. One of the typical features is a purple discoloration of the skin. When the deeper tissues are injured, the skin on the superficial area turns purple. Okay. And very difficult to manage also. Okay. Only thing that you can do in a deep tissue injury is protect the area, immediate pressure relief, and wait for it to evolve. Sometimes the ischemia settles on its own, and sometimes reperfusion is enough. Sometimes the area will get necrosed, and there will be a punched out ulcer. So deep tissue injuries are extremely painful. Okay? So always keep in mind, bed sore will not always start, a pressure sore will not always start from the skin. Sometimes they can start from deeper tissue and progress upwards. So a typical feature of a deep tissue injury is a purple discoloration of skin. Any questions on staging of bed sore? These two things, unstageable bed sore and deep tissue injuries, are what we have, the new guidelines have included in the last 7 years, 7 or 8 years. Any questions on staging? So in the management of bed sore, important thing is assessment with a focus of prevention on patients who are at a higher risk is very important. Stressing again, prevention is much easier than to manage. So for that, we need to clearly assess patients. For Indians with a darker complexion, assessment can be sometimes challenging. If you look at this image, here is a stage 1 pressure sore just evolving. Okay, as you can see, there is some discoloration in this area and some redness. Okay, and because of this complexion, we will not know whether it is a blanchable or non-blanchable redness. Only thing is that you can just touch that area. A fresh or a recently developed stage 1 bed sore will feel very cold because of lack of blood supply. And if the inflammation sets in, it will turn warm. So we just look for this temperature difference in that area in those who have dark complexion. And this feeling of this area is very important because many of these patients, when we turn, we'll quickly touch the pressure points. Occiput, scapula, sacrum, buttocks, and heel. Just quickly touch the area, quickly look at this area, and we make sure that there are no skin changes. This assessment is very, very crucial in catching the bed sore early and also to arrest the progression. So some of the preventive and management steps in bed sores overlap. In a patient who's bedbound, we insist on position change every 2 hours. Okay. And a patient who's wheelchair bound, we insist on position change every 15 minutes. So when we sit, the pressure is much more on the ischial tuberosities. The pressure reaches all the way up to 300 millimeters of mercury in the ischial tuberosities. And pressure over 80 millimeters of mercury is enough to cause ischemia. Okay. Pressure more than 80 millimeters of mercury for 2 hours is enough to cause ischemic injury. But when we sit, okay, the pressure can reach up to 300 millimeters of mercury on the area there where the pressure is. And when we lie down flat, the pressure is almost at 150 millimeters of mercury. So to develop a pressure injury is very, very easy for a bedbound patient. That is what I'm trying to convey. And we use special mattresses, air bed, water bed. And just because we have an air bed and water bed does not mean we overlook position change. Even in the presence of air bed and water bed, we still have to rigorously implement 2-hourly position change for a bedbound patient. Just 1 minute. In addition to that, pressure change, position change, nutrition is very, very important. Improving nutritional status significantly improves a bed sore outcome. If a patient has bed sore, the wound healing is much faster. And if the patient is bedbound, the risk of pressure sore decreases significantly in a well-nourished patient. And exercise is again important. Exercise pumps up the muscles and improves vascular supply. And hygiene, preventing urinary and fecal incontinence, if there is, managing it quickly is also important. We discussed all this. So in a bed sore, use of antibiotics should be, it is not when there is a bed sore, we always use antibiotics. If there is a bed sore, we observe the bed sore for 2 weeks. Just by dressing change, we bring down the bioburden, which is dead cells and bacteria, just by cleaning. Okay. And if the bed sore doesn't heal or is not healing, then we use local antibiotics. So we continue local antibiotics. and we wait for 2 weeks. And then even then the bed sore is not healing, then only we go for systemic antibiotics. So usually this is how the guidelines recommend. Just a bed sore, try only dressing for 2 weeks. See if the wound is evolving towards a healing bed sore. Then you continue dressing. If not, we include antibiotics and look for other causes of delayed healing. And even then, if not, we go for systemic antibiotics if there are infections. And keep in mind, diagnosis of wound infection in all ulcers, whether it is a bed sore or a malignant fungating wound or a venous ulcer or an arterial ulcer, the diagnosis of wound infection is not a laboratory diagnosis or microbiological diagnosis. All chronic wounds will have colonizers. All chronic wounds will have colonizers. If you take a swab, send it for culture, it will grow. So diagnosis of wound infection is a clinical diagnosis. Okay. You look for local signs of infection and systemic signs of infection. Okay. If you take a swab, it will grow. And sometimes if you take a swab, you will immediately notice that the microbiology department will reject it. Because for a chronic wound, swab is not acceptable. For a chronic wound, if we strongly suspect wound infection, we send biopsy. Okay. Just a small portion of the wound is cut and sent. Okay. Swab will definitely grow something because all the chronic wounds are immediately colonized. Now we come to malignant ulcers. So malignant ulcer, different types of malignant ulcers we will see in a palliative care setting. Sometimes it could be just a primary tumor like we see in this patient, a carcinoma buccal mucosa fungating out. Sometimes it is invasion of an underlying tumor like in carcinoma breast. Sometimes what started in the duct can fungate out. Sometimes it could be a metastatic spread from a distant tumor. A patient who has carcinoma lung has cervical node mets and the node is swelling up and it is getting ulcerated and fungating out. Okay. So different types of malignant ulcers we will see with different behaviors. Sometimes a chronic wound can turn into malignant, as in Marjolin's ulcer. When you look at patients with malignant ulcers, we can separate the suffering in 4 big domains: physical suffering, psychological suffering, social suffering, and physical suffering. In physical, there is bleeding, there is pain, and the presence of necrotic tissue, which causes malodor. There can be heavy exudate, wound infection is possible. Malignant ulcers can sometimes be pruritic. Okay, patient will have very severe itching, and they can also evolve into a fistula or a sinus. Psychologically speaking, malignant ulcer is always associated with a lot of psychological problem. There will be body image concerns. Patients will not want to come out of their room, go out in public. Okay. There will be a lot of embarrassment and shame. Okay, a female patient with a fungating breast swelling, very, a sense of shame is very much there in such patients. There can be denial, as I said in the first example. Patient will find it extremely difficult to accept that this ulcer is going to be non-healing. Okay. Always, most of these patients, it is a very good idea to screen for depression. Okay. And there will be a lot of fear on how this wound is going to evolve. Will it become big? Will it rupture? Will it bleed? If it is associated with some lifestyle choices of the past, there may be guilt. Sometimes patients themselves may feel very revulsed and disgusted about the appearance and the smell of their wound. All these problems, leads to severe psychological distress. And it will be a very good thing to screen for distress using distress thermometer in such patients. And these patients can also have sexual problems. Okay. The chronic pain itself decreases libido, and because of all this revulsions, malorder. There will be a lot of intimacy issues between the spouses. Socially, there are other issues, communication difficulties in patients with orofacial malignancies. The impact it is going to have on the family. One person should always be there at home with the patient. One person should take up the role of a caregiver, probably losing their employment and economic opportunities. And this transition to a role of a caregiver also is a very significant transition. Patients and the families may feel overwhelmed. The restrictions imposed by dressing changes, family can feel isolated with lack of support. Families can feel isolated from the society. So all these concerns may be seen in a patients with fungating ulcers. Adding to that, spiritual distress uh, can be very significant. Spiritual questions uh, can be very intense. Sense of abandonment can be very intense. Okay. Sometimes patients can draw strength from spiritual sources. This is one verse I often find it interesting, especially in terms of talking about malignant ulcer. This person says, "My flesh and my heart may fail, but God is my strength and my portion forever." Uh, so there can be a spiritual strength also through the difficulties for some patients. Similarly, in terms of psychological issues, we talked about negative aspect of social isolation, but in a patient is suffering, when the family is suffering, society coming in and to support the patient can be a sense of big social relief for the patient. We typically see this in Kerala where volunteers take turns to go dress the patient, volunteers take turns to go bath the patient, volunteers take turn to take the patient out, take them around the street, just so that they get a breath of fresh air. All these things can have a positive impact on patient. So approaching malignant ulcers, we should get away from focusing on the wound first. Okay. Always keep in mind the wound is on the patient. So our assessment always starts from the patient. Okay. One of the things that we assess is the ability of the patient to care for his or her wound, or the ability of the family to care for patient's wound. This is a very important step because we know that this is going to be a chronic problem. We know that this is going to be a long-term problem. So what kind of support they will need? What kind of assistance they will need? If I teach them dressing, will they able to continue? Are they motivated? Is the patient is coping well? These kind of assessments are very, very crucial when we talk about managing malignant wound. Other issues like nutritional status, what is the cause of injury? Are there any other treatment options still available? All these things should be discussed and clarified with the patients, or else they will keep running everywhere looking for some cure. So these communications, clarifications needs to be taken up by care providers. And then after assessing the patient, we focus on the wound. And this time we extensively assess the wound. Where is it located? What is the etiology? What is the size? It is always a good idea to take a picture and attach it to the patient's case sheet so that we know how the wound is evolving, how rapidly it is progressing. So all these things will help us manage and anticipate problems. What is a type of tissue? In a malignant ulcer, there can be a viable tissue, there can be a non-viable dead tissue, necrotic tissue, slough. So multiple different types of tissue we will see in the same wound. And how are we going to manage these different types of tissues in a wound? We will see. Are there any signs of infection? Again, it is not a microbiological diagnosis, it is a clinical diagnosis. And pain assessment becomes very, very crucial. Malignant ulcers are chronic ulcers. So these patients are likely to have chronic pain, and these patients will usually require round the clock analgesia. So, and we also look about what different types of pain. Are there any pain that we induce because of dressing and how can we mitigate that? What is the condition surrounding the skin? As I said, this pruritus is usually in and around the skin because of some, we will discuss that. So important thing to know, if the malignant ulcer has tendency to bleed, if a malignant ulcer has tendency to bleed, and if this bleeding is recurrent, then we should keep in mind this bleeding may escalate. Okay. Sometimes we call them sentinel bleedings, especially ulcers in and around head and neck. Okay. Sometimes there can be a severe carotid blowout. And how are we going to prepare the patient, family, and ourselves for such events? So these assessments needs to be carried out early in the treatment. The focus is to promote comfort. So in an acute ulcer, we look towards wound healing. In chronic ulcer, though we dress, it does not mean we do not have any aim. We just keep dressing. No, we still have certain things that we want to achieve. We want the patient to be as comfortable as possible. We want to build confidence for the patient and the family so that they are confident to manage the wound by themselves. They are not overwhelmed by the appearance or this growing chronic wound. And we always want to prevent this isolation. Isolation can be very dreadful. Okay. And isolation can accelerate the psychological problems like depression, anxiety. You leave them to themselves, their mind gets clogged with lot of negative thoughts, sense of abandonment. So we always look to keep them engaged and surrounded. And ultimately, we do all this with the aim of improving their quality of life. Dressing at home can significantly improve quality of life. Okay. Having a malignant ulcer is a very stressful thing, and having to travel every day with this malignant ulcer is a big, much more stressful thing. Okay. Keeping them at home is always a good idea, and equipping them with necessary skills to care for their wound is very important. Many things can be prepared at home. Saline can be prepared at home. Dressing material can be prepared at home. So how do we make saline? Just teaspoon of salt in a liter of water, or a pinch of salt in a glass of water. Okay. When the water is boiling, you add a pinch of salt. We take 1 liter of water. When the water is boiling, we add 1 or 2 tablespoons of salt. That is saline. When it is cold, we use it for dressing. How do we make dressing material? We cut soft cotton cloths, cut them into pieces, put them on idli vessel, steam it. It is like autoclaving, but not as effective as autoclaving, but good enough, much better for patients with malignant wound. And these steamed clothes can be directly applied on the wound. So simplify the dressing. Let's not complicate the
So-
dressing by. Yes. Somebody said
So
something.
can we put a bit of Vaseline and then steam it
Yes.
so that it won't stick to
Yes.
the wound?
Yes. Use of Vaseline I will discuss. So in not in all cases we will use Vaseline. You're basically talking about a non-adherent dressing. So these malignant wounds are
Yes, sir.
very sticky, and when you remove the dry dressing, they will damage the wound bed, causes pain, bleeding. You can definitely use Vaseline, okay, or paraffin, whichever is available. And when you steam it, apply it, it will just liquefy and spread throughout the cloth. But one problem with this is you cannot use it on a wound which has active infection. It will accelerate the infection very fast if you apply it on an active wound which has active infection. We settle the infection, then we go for these things. So till then, there are other ways to minimize injury during dressing. Yes, I will talk about metronidazole. Okay. So we also look for specific problems while we manage malignant ulcers. There is pain, there is malodor, there is exudate, there is bleeding. Okay. We look at, there is pruritus, we will look at each and every one. Okay. How do we manage pain? WHO analgesic ladder. Chronic malignant ulcers, chronic ulcers are going to be chronic ulcers. So these patients will have chronic pain. So WHO analgesic ladder for chronic cancer pain applies here. Okay. According to the intensity, mild, moderate, severe, we choose the appropriate step and manage. In addition to that, there are specific issues. Incidental pain is common before dressing, So before dressing, dressing itself can be painful for these patients. How do we minimize? A rescue dose half an hour before dressing. The patient's already on morphine. So half an hour before the dressing, we administer a rescue dose of morphine and then start the dressing. That is one way. If it is severe pain, not controlled by a rescue dose, ketamine is useful. Okay. Just 0.25 to 0.5 mg per kg administered sublingually. Okay. And one problem with ketamine is it's very bitter. So patients sometimes may spit it out. So warn them that it is going to be extremely bitter. Drops of ketamine under the tongue. And 15 minutes later, completely blocks of pain. So you can do the dressing much freely. I use ketamine when I want to debride pressure sores. Very easy to debride pressure sore under ketamine support. So ketamine is very useful, and we also use when we transfer these patients. The transfer, causes a lot of pain, so we use ketamine in such situations. Other important thing is wet the dressing. Never remove dry dressing. Completely soak the dressing. Remove the superficial layer. In the deeper layers, we wet it with saline, preferably a warm saline, which is kind of soothing, and then remove the dressing. Okay. As ma'am said, paraffin gauze or a Vaseline gauze is very useful. If there are no active superficial infection, go for it. It is very easy to remove when you use these non-adherent dressing. Okay, but not be used in an active infection. There is lot of foul smell coming from the wound already. Do not use paraffin gauze. It will just accelerate, especially this anaerobic infections will grow very rapidly in the presence of Vaseline gauze and paraffin gauze, because basically they will block the air circulation. They will mask the wound completely. So these anaerobic infections will grow very fast. Another issue is, another thing that you can try is bupivacaine. It's a spinal anesthetic. We soak it in a gauze, put it on the wound bed for some time and wait for 5-10 minutes and then remove the gauze and clean the wound bed. If the wound bed is very raw and very painful, you can try this. Other things I've seen nurses do is we have done is mix lignocaine gel in metronidazole and apply it on the wound bed. Post dressing, after 5-10 minutes, patients will complain that it is burning. So this lignocaine applied on the wound bed can help minimize it. So this is it. Non-adherent dressing. Maintain moist wound environment. Never remove dry dressing. And if the patient has very severe pain during dressing, go for dressing that is likely to stay in place for a longer time. Always ask this question. There is no active infection. Should I change the dressing daily? Can I go for an alternate day dressing? Only thing is that you may have to use local antibiotics like metronidazole to inhibit bioburden or bacterial growth on the wound bed. Okay, and irrigating the wound will with warm saline will be very soothing for the patient. Another one peculiar issue with malignant ulcers is malodor. Malodor can be because of an infective origin and also a non-infective origin. Non-infective origin of malodor is just the presence of dead skin, dead cells, necrotic tissue in the wound can produce malodor. If there is a necrotic tissue, anaerobic organisms will flourish there. That will produce malodor. So one very good drug against anaerobic infection is metronidazole. Metronidazole severely inhibits anaerobic growth. Okay. So if the patient comes to you with malodor, and this is becoming a recurrent problem, it is always good idea to start the patient on metronidazole therapy. Okay. This is a sniff protocol, we call it. It is published in BMJ. This protocol was tried in CMC Vellore. If you can get hold of the article in BMJ, you can read it. If the patient has a faint malodor, keep them on 200 mg metronidazole indefinitely. So the problem with local metronidazole is that it doesn't penetrate deep. And many of these sometimes malignant wound ulcers may have deep-seated necrotic tissues where superficial metronidazole will not penetrate. So even if you give orally also, it may not significantly penetrate, but better. So keeping them on just 200 metronidazole is very good. If they come to you with foul smell, give them metronidazole 400 TID for 7 days. And after 7 days, continue 200 mg orally indefinitely. Keep continuing. So they have found that by doing this, repeated readmissions due to malodor has significantly come down. So we try this. We do this. Currently, I am focusing on research with my PhD work. Before this, I was working in a hospital, and we do this for patients with a very fungating, forbidding smell, malignant smelling ulcers. Oral metronidazole therapy is very, very effective. So if they have come with a very forbidding smell, 2 weeks metronidazole orally, followed by 200 mg orally indefinitely. So if you Dr. Twycross palliative care formulary. So that palliative care formulary by Dr. Twycross also has this sniff protocol. So it's a very effective strategy to minimize foul smell. So if it is due to infection, okay, treat the infection. So whatever antibiotics that we use commonly used antibiotics for wound infection in our setup is we use amoxicillin, clavulanic acid, cefotaxime. Sometimes, taking a small biopsy from the wound and sending for culture helps, but never a wound swab. Other measures are topical metronidazole, activated charcoal really helps. Activated charcoal is uh, in Karunashriya, they prepare their own charcoal. They burn the wood, prepare charcoal, autoclave it, and use it. Some charcoal dressing is available as a commercial product, but costly. Uh, Charcoal absorbs all the smelly molecules, so it brings down the foul smell. Occlusive dressing is good. So even when there is a foul smelling wound, just covering the dressing, making it airproof will help. But the problem is, if you in an active infection, you put an occlusive dressing, you are cutting off oxygen to the wound bed, and anaerobic infections will flourish. So occlusive dressing is always done along with metronidazole, never independently. So other external therapies like deodorizers in the room, oils will help. Again, exudates does not mean infection. Malignant ulcers by themselves produce a lot of excessive exudates. Increased vascular permeability is one of the cause. So if there are exudates in a malignant ulcer, does not mean it is infection. Okay. So if it is foul smelling and if you see local signs of infection, then antibiotics will help. If it is not because of infection, antibiotics will not help. Only thing we manage the exudates with absorbent dressing. Absorbent dressing, okay, we have foam dressing, we have microfiber dressing. These are commercially available products, again costly. In our general setup, resource limited setting, we just use multiple pads to absorb them. And charcoal dressing also helps with absorption. One problem with excessive exudates is maceration. Because of the moisture retained in the dressing, the skin around the wound also gets moist and the skin gets macerated. So, and once they are macerated, the wound expands very significantly. The macerated area quickly ulcerates and peels off, and the wound becomes much bigger. So, peri-wound skin maceration should be prevented. So, if there are wounds with excessive exudate, one good idea will be to apply Vaseline or any oil-based paraffin around the wound bed so that the moisture doesn't come in contact with the skin. So this emollients or moisturizers will act as a barrier between the moisture content released and the skin. So peri-wound skin maceration is a significant problem with exudate. So in such cases, we use absorbent dressing. So suctioning, negative pressure wound dressing can be tried if we are in an inpatient setup. Bleeding can be a significant problem in patients with malignant ulcers. Even when we see a lot of excessive necrotic tissue in a malignant wound, we often refrain from debridement. Either a mechanical debridement or a sharp debridement, we often avoid because malignant ulcers have tendency to bleed. Okay. Sometimes dry dressing change can cause bleeding. So we always look to prevent such interventions that increases the risk of bleeding. So always wet the dressing before removal, and non-adherent dressing like Vaseline or a paraffin gauze dressing again minimize the risk of bleeding. So minor bleeding can be controlled with local application of sucralfate powder. In Calicut, when I worked, sucralfate tablets were available, which are usually powdered and applied. But in Tamil Nadu, sucralfate tablets are very hard to find. So this may not be a suitable intervention when it is not available. So, but it helps, especially wound bed, which has slightly an acidic wound bed, will work very well when we apply sucralfate. Sucralfate we consume for patients with gastritis, gastric ulcer. No? They form a barrier. Same principle applies here. We apply sucralfate powder on minor bleedings. It just forms a barrier there, occludes the area. If the bleeding is slightly profuse, we use adrenaline. 1:1,000 adrenaline is the strength that we use. The ampules comes in 1:1,000 strength. So we directly break the ampule, soak in the gauze and directly apply. You don't have to dilute it. One issue is if you are using adrenaline, keep the compression for a minimum 10 minutes for it to be effective. Don't keep removing and reapplying. That will not help. Some risks are associated with adrenaline. Adrenaline is a very potent vasoconstrictor. If the wound bed is raw, sometimes there can be some systemic absorption. Temporarily, patient's heart rate may shoot up and patient's BP may shoot up. Very rarely, I have not seen it, but I've heard people telling it. I've read case studies with this problem when the wound bed is raw, where adrenaline gets absorbed. Other issue is very, very rare is avascular necrosis, happens only at the tips when we use adrenaline. Sometimes another problem is rebound bleeding. Adrenaline arrests bleeding by vasoconstriction. When the effect of adrenaline wears off, when the vessels dilate, sometimes there can be rebound bleeding. So, but it is a very useful tool in managing profuse bleeding. Tranexamic acid is useful, especially in any bleeding. Giving tranexamic acid systemically, keeping the patient on regular dose of tranexamic acid is helpful. Locally also we can use for oropharyngeal bleeding. We often use tranexamic mouthwash. Just mix 5 grams in a 50 ml of water and tell the patient to rinse. Helps. Okay. Always keep in mind, a recurrent bleeding from a malignant ulcer can be a sentinel event, okay, which is a harbinger of a massive blowout, which can sometimes be fatal. So prepare the patient, prepare the family. Always keep dark clothes with you, just to mask the effect of bleeding. Okay? Dark clothes, green color clothes, blue color clothes, and the patient is having a catastrophic terminal bleeding, and white cotton can be very visually distressing for the patient and the family. So placing some dark clothes are very, very helpful. And sometimes you may have to quickly sedate the patient to reduce this anxiety. I remember one of our patient, very young boy, 16 years old, had a fungating ulcer in the neck. often it was bleeding. We were really worried about a carotid blowout one day. And like we were anticipated, it was not a carotid blowout, but he started bleeding very profusely. And he was getting very anxious, looking at the bleeding, looking at it. And we gave repeatedly midazolam. Once he calmed down, the bleeding also settled. And few days later, the boy died very peacefully. We were worried he is going to blow out and bleed and pass away, but he slowly died without any bleeding event. Sometimes midazolam will help to calm the patient. So it will be very useful intervention to sedate them when they are having a massive bleeding. Itching is one problem. Two reasons for itching. One is the skin that gets stretched when the ulcer fungates. So that can cause itching. Okay. One useful intervention is applying moisturizers. Sometimes patients with itching which are not controlled by this, people say that TENS helps. I have not tried it. So you can try it. People have said TENS helps. Some literature I read have used TENS as an intervention in patients with intractable itching due to malignant ulcers. Technically speaking, we don't use TENS when there is an open ulcer, but there are some reports of TENS helping such patients. So debridement, we don't do an active debridement in a malignant ulcer. So we always look for these autolytic or enzymatic debridement. If there are excessive dead tissues, autolytic is you just keep changing the dressing slowly, it will fall off by itself. Enzymatic is you use some debriding agents like papain-urea, cellulase to debride the dead tissue. Very useful when it is a bed sore. If it is a bed sore with a lot of dead tissue, which is delaying the wound healing, definitely debridement will significantly improve the healing rate. This is how we debride a bed sore. And sometimes if you are not able to debride everything at once, we make these diagonal cuts and start peeling them off from the edges. We try this in a home care setup where you cannot debride everything in one shot. Just superficial cuts we make and they just start peeling off so that we don't cause significant bleeding at home. Maggots are one very serious problem in patients with malignancies. If you notice maggots in a patient with chronic ulcer, you can be 100% sure that the wound care is very, very poor. It doesn't happen in a wound that is cared for every day, regularly, dressing is changed. Maggot infestation doesn't happen in such wounds. They leave the wound open, don't dress, leave it. Flies will come, lay their eggs. After a few days, you can see maggots coming out. Can be extremely distressing for the patient. Can be painful also. So management of maggots, mechanically can remove them one by one with forceps. That is one. We can irrigate them with antiseptics. Sometimes with chlorhexidine, maggots can die. One common interventions for removing maggots is turpentine. You would have seen it. Turpentine produces fumes which are very irritating for maggots. So we soak gauze and turpentine, place it near the wound bed, okay, and then close it. Those fumes will irritate maggots and they will come out. So that is one intervention. But there are other things. Maggots needs air to breathe. Okay, they breathe oxygen. So suffocating them is again another intervention. You place, if the wound bed is flat, you place the Vaseline gauze, 2-3 layers, block the air circulation, keep it for 48 hours, all the maggots inside will die. Okay. But one problem with this intervention is this suffocation increases the risk of anaerobic infection. So use this along with metronidazole. Again, maggots are photophobic. The moment you open the dressing, the maggots that come to the wound bed to feed on the dead tissue will immediately grow into crevices. They don't like light. They are photophobic. So peekaboo is another intervention. Just close the wound bed, keep it for 5 minutes, open quickly and remove them. Again, close it. They will come out to feed again. Open quickly and remove it. But time consuming. Okay, you may have to give pre-analgesics because this is going to be time consuming. So I often found turpentine to be effective and also suffocation to be effective. Suffocation, whatever the maggot dies inside the wound bed, no, it will be cleared off by the macrophages slowly. So just with regular wound dressing and your topical metronidazole, this will settle on its own. Don't have to worry about maggots getting stuck there.
What
So,
about hydrogen peroxide, sir?
ma'am, it is not effective. I've seen it being used in many general setup, but in the general setup, you don't see a significant maggot infection. Where in palliative care, we have picked up around 500, 300,000 maggots, very badly. So we found hydrogen peroxide is not at all effective. So better is turpentine, just that fumes irritate them. You pour
Is there
hydrogen.
any role?
Yes, sir.
Is there any role of vinegar?
I have not tried, sir. Sorry.
Okay.
I have not tried. If you have tried and you have some experience, please feel free to share.
No, I don't have any experience with
I have
maggot.
not tried. I do not know if Chechi is here. No, she's not here. Shiva Chechi, I have not heard from other nurses also about vinegar. Vinegar I have used for when there is acetic acid dressing, no? Is very useful if there is Pseudomonas infection. Pet sores with Pseudomonas infection, acetic acid will severely inhibit the Pseudomonas infection. I recently had a patient in the hospital where I worked before. Just acetic acid dressing significantly brought down Pseudomonas infection and patients' bed sore healed very fast. So do not forget this compassionate touch. Okay. For a person who has some fungating malignant wound, one thing that he will be lacking in his life is that people are not touching him. Okay. As a doctor or as a nurse, when you care for them, just holding their hand, touching them can speak volumes to them. So please feel free to touch them, hold their hands. They may be really in need of that. This does not apply to malignant ulcer if you are managing other chronic ulcers like venous ulcers, pressure. So nutritional support is very, very important. Okay. Minimum requirement is 30 to 35 calories per kg per day for these patients and minimum 1.5 grams of protein per kg per day for these patients with chronic wounds, diabetic ulcers, pressure ulcers, for them to heal. Some anecdotal evidences are there about the role of zinc, vitamin C, arginine, and in patients with diabetic ulcer, glycemic control is important. So if there is some role of radiotherapy, chemotherapy, surgery, hormonal therapy, explore. Their roles are very limited. For example, we had a patient with a osteosarcoma who had a uh, uh, swelling of the bone in the fingers and it was often bleeding. So we had to amputate the finger because bleeding was more distressing for that patient. So even then there was a role of surgery. Patient with very painful fungating ulcers, radiotherapy has a role because radiotherapy causes fibrosis, reduces the bleeding chances. Bleeding wounds, fungating wounds responds to radiotherapy. So discussing with radiation oncologist, it's all helpful. So in end of life care, in a patients with malignant fungating wound, comfort takes priority. Okay. Don't be very strict on daily dressing. Daily dressing may not be needed for such patients. If there is no infection, look for alternate day dressing or once in 2 days, 3 days. Uh, so, but do not abandon. So they should feel that they are being cared for even at end of life phase. We may minimize our intervention, but we will not minimize our presence. So just stressing on this setting realistic expectations again. Initiate this conversation of non-healing nature in a malignant ulcer much early. And we always look to limit the impact. We know that this ulcer is going to be long-term non-healing. How much function can I preserve for this patient? How much quality of life can I improve? That is very important. Always break this chain of isolation. For my patients with orofacial malignancies, I often say, whether they are male or female, dress the wound, help your spouse in cooking, cutting vegetables, sweeping the home, watching the kids, engage them in family routines just to break the isolation. It's very helpful. I'll stop now. If you have any questions, we'll ask, we'll discuss. Somebody wanted to know about metronidazole. I hope I answered metronidazole therapy. If you have any clarifications on that, please feel free to ask. Sir, I don't think there are any questions.
We can wind up. Thank you. Thank you, sir, for, and even if in the last moment you have request for us for this meeting, thank you very much for that.
Yes,
Thank
I'll
you.
send you the PPT. Sir.
Yeah, sure. Thank you everyone for joining and meeting in this decision. Thank you everyone. Thank you. Let's see in the next session.
Thank you.